It is, of course, my honor and my pleasure to present to you Professor Vincent, who will talk about this organ failure score. Should we rethink it? The floor is yours.
So, I think the topic has already been addressed, naturally. Should we revisit our organ failure scores and try to include a gut GI element? First of all, I believe, like most of you, I'm sure, that the gut is really a very important organ. And we do not assess it very well. We do not assess the function very well. We do not assess the structure very well. It's not only about dysbiosis, the microbiota, it's about the altered gut permeability with translocation of bacteria and their products. It's a lot of immunological aspects, and I am particularly interested in hemodynamics, reduced splanchnic perfusion. And all of this will result in changes in interactions between the various organs. We do not consider it enough, but the gut is actually in connection with all the other organs. You can read that recent paper to have a review of these elements. Physiologically, when our body is in trouble, it's as if there was bleeding, hypovolemia. And the idea is that we do not eat when we are in trouble. We try to protect our brain because it's the right time to think at what we will do when we are attacked. We need to have enough heart going to the heart because we will have to pump more blood. But to maintain blood volume, we can reduce splanchnic blood flow, and we have even better reasons to reduce renal blood flow because we want to keep our volume. So the kidney, of course, is also endangered. But when we look at physiology again, and this is a recent review which is open access in critical care, we can see that actually the gut receives the highest proportion of blood, even more than the kidney. It's something in the range of 25 to 30%. And the gut has also this particular anatomy in that the tip of the villi may not receive much oxygen. How can we quantify it? How can we have access to that? It's frustrating. Some of you, the oldest people in the room, may remember, like me, the gastric tonometry. Gastric tonometry, it was a modified NG tube with a balloon going close to the gastric mucosa, and so we could look at the degree of ischemia of the gastric mucosa. Initially, it was the intramucosal pH. Then we looked at the PCO2, reflecting decreased blood flow to the gastric mucosa. And interestingly, we must be interested in evidence-based medicine, right? This is a study whose results were published in The Lancet, very credible data, showing that using it could result in lower mortality rates, especially when the intramucosal pH is rather normal to start with. It would be a way to prevent any complication. And gastric tonometry has disappeared, okay? It's not something we still speak about. We can actually not buy the tubes any longer because there were too many artifacts. So it's just to say how frustrated we are. We do not have a good way to monitor the gut. Okay, so I will not repeat what has been said. I think it's very important, difficult to show, but very important to feed our patients early, to try to limit the gut atrophy by enteral feeding. I think that makes a lot of sense. In the future, we will also focus more on the microbiota. But today we are not very good at influencing the gut function. Of course, we can limit diarrhea, constipation. Okay, no. Let's do more. We lack GI drugs. So this is also, well, I already quoted that paper. It's a nice review from Annika in Current Opinion. And it shows how we really address the question. We speak about abdominal distension, we speak about absence of stool passage, abdominal pain, diarrhea, GI bleeding. How do we quantitate that? That's the issue, quantification of these elements. So how can we deal with that? Complaints of abdominal pain, some of our patients are even sedated. Nausea, well, they may have a GI tube in place. Abdominal physical examination with all its subjectivity, GI distension, vomiting, how much, high gastric residual volumes. That could be, as we know, a talk by itself. We tend to believe that we should not even look at those. I still believe there is a place for looking at gastric residual volumes, but it's not that important. We should look at other elements as well. Diarrhea, how do you define it? How much is it? Paralysis of the lower GI tract. So many patients are concerned with variable incidences, so we would like to quantitate it. And GI problems are associated with higher mortality. That's not surprising. Any abnormality is associated with higher mortality rate. That's a general rule, at least. So, you asked me, what about SOFA? Well, please remember that SOFA score have been developed to describe the severity of organ dysfunction. Describe. It's not to predict mortality. That's called Apache. That's called SAPS. These are scores to evaluate the risk of death. And you put H in it, and you put cancer, and you put other elements. These elements are not in the SOFA score. So the idea, and that's very important, is to have objective assessment using variables which are obtained everywhere in the world. They should be simple, easily available, obtained routinely, and specific for the function of the organ. And independent of therapy whenever possible. Of course, this is ideal. It's not always possible. But when we developed the SOFA score, it was by consensus. It was in Versailles, nearby Paris, many years ago. And we had several groups. We had actually 7 groups. 6 groups came back with some proposal to quantitate the severity of a given organ, the lungs, the brain, etc. And the 7th group, led by Brun-Buisson from Paris, looked at GI score. And they came back and they said, sorry. That's a failure, we cannot. So you know the SOFA score, you know the limitations, okay? You may say that for the respiratory system, the degree of alteration in gas exchange may depend on the way you ventilate the lungs, the PEEP level. Okay, we want to keep it simple. You may say for the cardiovascular system, it's basically the need for vasopressors. Yeah, because we cannot use anything else. But for the gut, it's really difficult to come up with something meaningful. So indeed, then in 2023, we started to think at the update of the SOFA score. And actually, we couldn't find many things that have changed. If we consider that ECMO, of course, is used only in failure, that renal replacement therapy, of course, is used only in failure, there is not so much to change. But okay. I'm not here to speak about the SOFA 2. I'm here to go back to how we could assess GI function. Poor tolerance to enteral nutrition, how do you define it? Nausea, vomiting, how do you define it? Diarrhea, how do you define it? Abdominal pain, distension, how to define it? Intra-abdominal hypertension, oh, very important. I agree, and in Brussels we believe that this is an important aspect, but of course there are many patients who do not have intra-abdominal hypertension. Okay, so that won't work. So this group of investigators came out with a Delphi consensus process. So, okay, let's sit down and let's evaluate the variable we could put in a score. But indeed, there are variables which are associated with abnormalities that you could identify clinically, but there are also therapeutic interventions, okay, like post-pyloric feeding, use of prokinetics. So the score at least could be altered by the doctors. It could be even proposedly altered if we take it as a criterion for inclusion in a trial, for instance. We could add some prokinetics and say, okay, now the patient could be enrolled in the trial. It would be less plausible with vasopressors if the patient does not need a vasopressor. But at the end of the day, that's what they came with. And we can see it's complicated. It's too complicated. So the SOFA-2 score was developed. Some people were more enthusiastic about the work on the SOFA-2 score than myself, but that's okay. And, you know, for the individual values, it was very close to the SOFA score. SOFA-2 is very, very close to the SOFA score. Look at the individual scores there. It's the same with SOFA and SOFA-2. Look at the relation with death, because we still need to have some relation with mortality. And it's basically the same. But we couldn't add something on GI dysfunction. As here again, another trial, which is a bit actually older, it's 5 years ago. And with such a list, we cannot do much. We cannot do much. It's too complex and too subjective, and unfortunately, it will not work. We heard the very nice presentation by Pierre Singer, who alluded to his work in 2019. But this subscore would not fly, Why? Because you need to measure the resting energy expenditure. We do not all measure it routinely in our ICU. So no, that's against the principle of the SOFA score to have something that we can quantitate anywhere in the world in any intensive care unit. So that won't work. And it didn't work so well, but okay. So in summary, the gut is very important. We need to find better ways to assess the GI dysfunction. Here, the authors of this recent review wrote that a single sign and symptoms does not reflect GI dysfunction adequately. We need a set of variables, and that makes it difficult. Now, yeah, we could perhaps have better tools reflecting GI motility. We could find biomarkers for response to enteral nutrients, including absorption. But do you measure any of these things routinely? First of all, we are not convinced that these are very good biomarkers. And secondly, no, it's not something that we propose to measure routinely everywhere. So I'm afraid I'm not very enthusiastic here. I don't know what to propose. I would love to have really good tonometry, something that could be easily inserted in the stomach, why not, and which could really assess the degree of health of the GI system. But unfortunately, at this time, it's too complex, and it's not really in the agenda. You have not seen it in any of our sessions, I believe. So thank you very much.